Okay, lovely. Hi, everyone. Good morning, good afternoon, good evening, wherever you're joining from. My name's Millie, and I'm the Technical Partnerships Advisor for Start Network's Crisis Anticipation and Risk Financing team. And thank you all for joining us today. So welcome to the final Global FOREWARN meeting of 2023. As you know, we'll be focusing on anticipating health risks today. And it's great to see so many people slowly joining as we get started. As usual, really hoping that this meeting will be as interactive as possible. And we've done our best to leave a bit of extra time at the end for Q&A. So please do add your name, your organisation, the country you're joining us from into the chat. Say hello and feel free to be posting your questions and comments as we go. Just before we kick things off, I just want to flag that there will be presentations in both English and French today. So to make sure that you're able to make the most of today's content, please do make sure you're in the correct channel for the language you would like to listen in. So you can do this by selecting interpretation from the panel at the bottom of your screen, and then you can choose the language that you would prefer to hear. So as explained on the screen here, you'll hear both the original audio as well as the interpretation where that's relevant. But if you'd prefer not to hear the original in the background, there's also the option to mute your original audio as well. So just quickly onto the content of today's call. We'll start very soon with some opening remarks from Dr. Manuela Christopher, who is joining us from Madagascar. But before I hand you over, I'll just run through the order of the day. So first of all, we'll hear about the way that the START Fund has been used to date to access financing in anticipation of health risks. We'll then hear from Tilly Alkena, who works with the Anticipation Hub hosted working group for health and anticipatory action. After that, we'll have Atik Hassan joining us from Bangladesh, and he will talk through a technology-based approach for the early detection and control of dengue in Bangladesh. And finally, we'll hear from colleagues at CAFOD who have previously implemented an alert in anticipation of Ebola in Uganda. So there's plenty to get through today, and we're hoping, as I say, there'll be lots of time for questions and discussion. So please do add your comments as we go, and we'll try and collect them all for our speakers, either during their presentation time or at the end. So I think for now, I'm handing over to Anthony Ratsimbazafi, who's joining us from Madagascar and who will introduce our first speaker. Anthony, over to you.
Hello, everyone. So thank you, Millie, for giving me the floor. So I'm going to introduce you. Dr. Manuela is the director of in the Ministry of Santé, Ministry of Health in Madagascar, from the Direction de la Veille Sanitaire et de la Surveillance Épidémiologique et Riposte. So the floor is yours, Dr. Manuela, and thank you.
Merci beaucoup, Anthony, de m'avoir donné la parole. Comme on a discuté, mesdames et messieurs, je vais parler de cette ouverture. Mesdames et messieurs, chers collègues et partenaires ici présents, c'est un grand plaisir et c'est avec un grand honneur et profond engagement envers la santé mondiale que je prends la parole aujourd'hui en tant que représentant du ministère de la Santé publique à Madagascar pour pouvoir ouvrir cette réunion importante de la communauté FOREWARN, aujourd'hui axée sur la santé. Nous sommes réunis aujourd'hui virtuellement en tant que membres d'un comité mondial unis par notre objectif commun: anticiper, avertir, analyser et répondre aux risques sanitaires. À l'instar des pays du monde, Madagascar est confronté à des défis sans précédent. L'ampleur et la complexité des urgences sanitaires et humanitaires ne cessent de croître. Et depuis 2017, Madagascar a fait face à des épidémies d'une grande ampleur, avec les flambées d'épidémies de peste pulmonaire, épidémie de rougeole, la pandémie de Covid-19. De par son profil climatique aussi et sa position géographique, notre pays est confronté régulièrement à des catastrophes et à aléas naturels tels que les cyclones, les inondations, la sécheresse dans le grand sud de Madagascar. Aussi, Madagascar est considéré extrêmement vulnérable aux différents risques de catastrophes et au changement climatique. De plus, la santé de nos communautés est au cœur de nos préoccupations. Et c'est dans cet esprit de coopération et de solidarité que nous aborderons aujourd'hui 4 thèmes essentiels, chacun contribuant à renforcer notre capacité collective et à faire face aux menaces sanitaires émergentes. Le premier point à l'ordre du jour concerne l'anticipation des risques sanitaires grâce à Start Fund. Nous examinerons les approches novatrices visant à anticiper les épidémies en mettant en lumière le rôle crucial de Start Fund dans ce mécanisme. Il est impératif que nous investissions dans le mécanisme qui permette une réaction rapide et coordonnée pour protéger nos populations. Et notre deuxième thème aujourd'hui abordera la stratégie de contrôle de la dengue au Bangladesh. Nous explorerons les moteurs de cette maladie et discuterons de manière dont nous pouvons planifier des mesures de contrôle efficaces pour endiguer sa propagation. La collaboration entre pays membres est essentielle pour élaborer des stratégies transfrontalières et partager les meilleures pratiques. En troisième lieu, nous recevrons des mises à jour de groupes de travail sur la santé d'anticipation en mettant en lumière l'approche novatrice du Centre climatique de Croix-Rouge pour anticiper les risques sanitaires. Les nouvelles méthodes et les avancées technologiques jouent un rôle essentiel dans notre capacité à prévoir et à répondre aux menaces sanitaires. Enfin, nous explorons les projets d'anticipation mis en œuvre par les membres des réseaux STAR en mettant en avant l'action anticipée de la CAFOD en prévision d'une épidémie d'Ebola en Uganda. Ces initiatives exemplaires démontrent la nécessité de partager nos expériences et de tirer des leçons pour renforcer continuellement notre capacité d'anticipation. Mesdames et messieurs, cette réunion est une opportunité précieuse pour renforcer notre collaboration et partager nos connaissances. En travaillant ensemble, nous pouvons faire progresser notre mission commune de protéger la santé mondiale. Je vous encourage tous à participer activement aux discussions et à contribuer avec vos idées novatrices. Je souhaite à tous une réunion fructueuse et productive. Merci beaucoup de votre aimable attention.
Merci beaucoup, Dr. Christopher, d'avoir partagé un peu sur la situation à Madagascar et d'avoir souligné l'importance de la collaboration mondiale sur cette aléa de santé. Donc, merci beaucoup pour vos remarques pour commencer la journée. Merci.
Merci.
Okay, so we will continue now with our next speaker. So I'm sorry, apologies. No, first of all, I will start with a quick overview of Global FOREWARN and what does that mean. So those of you who've joined before or who've joined other meetings, you'll be very familiar with this slide, so I won't spend too much time on this. But just for those who are new to the community, FOREWARN is the forecast-based warning, analysis and response network. And the aim of this network is to bring together the right people to forecast hazards and hazardous events, and to support the humanitarians who are closest to an anticipated crisis. So the global community is everyone who's here today, brings together all parties who are interested in discussing specific themes, and as you know, today is health, but we've previously had several other themes this year, which I'll talk to in a bit more detail in a moment. We also have hazard-specific global subgroups, and these have a technical advisory role to the Start Fund and to Start Ready. And we also have 5 national networks of experts in 5 different countries, so Bangladesh, Philippines, Madagascar, Nepal, and Pakistan. Quick summary of 2023, as this is the last meeting of the year. I just wanted to do a really quick recap of what Global FOREWARN has been working on. So we've had this is our third quarterly meeting in online. In February, we had record numbers of people joining our meeting on landslides. And during that call, we had presentations from the Land Aware Network, the Landslip Project, and from colleagues in Nepal who presented their Bahero Alert app, which was funded through Start Network's tool grant. And we also heard from example implementations that had taken place with funding from the Start Fund. And finally, we heard from Project Ligtas in the Philippines and a community-based project in Bangladesh. Back in May, we had our Q2 meeting, and this one was focused on anticipating conflict. Some of you may remember we launched a guidance package during that call for anticipating conflict through the Start Fund. And this catalogued all of the available tools for conducting analysis ahead of potential conflict events. And that is available, of course, on our website. We also heard from OCHA, who presented some new research on the feasibility of threshold-based funding mechanisms for conflict events. We heard from 2 different predictive displacement models. And we also heard experiences of implementing Start Fund alerts in anticipation of conflict and displacement. In Q3, we did something slightly different. We brought together 54 representatives from Start Network member organisations who were all committed to anticipatory action. And they came together at an in-person meeting in London, along with several of our partners and different experts from within the network. We hosted workshops on a variety of topics, from technical analysis, forecasting and building anticipatory action systems, right through to inclusion, localisation, meal and advocacy. And the executive summaries from that meeting will be available very soon and circulated with the minutes from this call. Excuse me. Now in December, we'll be closing the year focusing on health hazards. And our first speaker is Emma Kazu, Start Network's meal advisor for anticipation and risk financing. And she's going to take us through the ways in which the Start Fund has been accessed in anticipation of health-related hazards to date. Emma, over to you.
Yeah, hi everyone. Thank you, Millie, for the introduction, and happy to be joining this call. So as Millie said, I'm Emma Kazu, I'm the meal advisor for the crisis anticipation and risk financing team. And today I will just give an overview of what's been done within the Global Start Fund for anticipation of disease outbreak. Next slide, please. So just some key figures. So there were 84 alerts that were raised since the creation of Start Fund, so since 2014, and only 15% of this alert were anticipatory, with an activation rate that's a bit lower with 70%, and some total amount dispersed, of course, a bit lower with 1.6 million and a total reach of 2 million. So we can see here that there is still a lot of response for disease outbreak, but we still have 50% of alert rates for disease outbreak, which is quite good. Next slide, please. As we can see, there were a lot of alerts being raised in 2020 and 2019, and since 2021, we can see a high decrease of the number of alerts being raised. I just want to highlight that I'm taking into account the Global Start Fund. And for example, in 2020, and 2021, there was a COVID-19 fund that was created specifically for COVID-19 type of response and project. And it's not taking into account into the slides. I'm taking the other type of crisis that was really related to the Global Start Fund. And as we can see, in terms of anticipation, we just had 2 in 2022, but we didn't have any since. So the slides are not really up to date because last week we had an anticipation of dengue alert that was raised, but it was activated. But unfortunately, the PSC decided not to award any project, so there are not any project being implemented for this at the moment. Next slide, please. Yeah. So on the first point, I will just trying to highlight why this alert was not activated. Why do we have a lower rate for anticipation that we have for response? So first of all, there are 3 main categories of why alerts will not be activated for anticipation in general. It will be the data used, the timing, and the Start Fund niche. So I'll just give some examples of the alerts we've seen that were not activated for anticipation. For the timing, for example, the alert was raised too late. For example, there were ongoing outbreak in other countries, and in these countries, they just decided to raise the alert 2 months after. so the allocation committee decided that it was not anticipation and it was not effective in view of the prolonged nature of the outbreaks elsewhere. Other type of decisions that were made, for example, were related to the start from niche. So usually the start from niche should be like a small to medium crisis, and it should be filling a gap. So for the first part, filling a gap, there were some cases where there were already funding available. So it will not have an impact to fund like a start from crisis, or at least not a meaningful one, as there were already a lot of funding available in the country for this type of crisis. Another case were geographic targets. So as I said, it's small to medium crisis. So sometimes the geographic areas targeted was too widespread and it was not targeted enough. And in other cases, for example, as the fund is a bit low and the location they decided was too remote, they decided not to allocate this. So of course, it's very country specific and context specific, but just to give you an overview of the things you have to consider when you want to raise an alert. And finally, one of the reasons some alerts were not activated was the information used. In one case, for example, the committee determined that the information was outdated, and new information during the allocation meeting indicated that the project was no longer needed, so it was decided not to award it. So these are things you have to look for. Yeah, you can go ahead. Thank you. So I'm just going to give you lessons from the activated alerts that we had. So as you can see, there were mostly projects for Ebola, cholera, dengue, and one for COVID-19. So it was from the Global Start Fund and not from the COVID-19 pot. And just so you know, we do have some crisis response summaries on our website. I can send the link. And on the website, you can find more information for every of these projects, on the activities done, the lesson learned, etc. if you want more information. Next slide, please. So example of activities that were implemented. So as I said, there were different types of disease. So of course, you won't be doing the same for Ebola and for cholera, but I just tried to summarize a bit the main categories and just to give you an idea of what type of anticipatory activities can be implemented within the 45 days we start fund. So first of all, it can be assessments, it can be epidemiological analysis, it can be mapping, testing, and treatment of strategic water points. It can be evaluation of knowledge and competencies of the communities or the health worker, for example. So it can be all this type of assessment that can be done during the start fund project. In terms of capacity building, we've seen a lot of WASH training for the health facilities and the communities. Then there were a lot of capacity building for the staff, the NGO staff. So how to ensure that the staff is knowledgeable and will not spread the disease and know how to work in health emergencies. A lot of activities related to community engagement and mobilization. So for example, in this case, it was through community health promoters and parenting awareness, which is the other type, which is a lot used for start fund anticipation projects, which is communication and sensitization. So it can be community hygiene promotion, community awareness campaigns, community sensitization, and mass communication. So it can be house-to-house visits, or sometimes a megaphone announcement, or any type of campaigns that can be done to raise awareness on the good practices of what should be done to avoid the disease spread, basically. Next slide, please. And then also type of activities that can be implemented would be anything related to preparation and provision of materials. So it's totally possible to do some activities such as prepositioning of essential commodities and supplies. So it can be like stockpiling essential medical items and prepositioning any other crucial supplies that are required for health facilities, for example. It can be wash interventions such as mass chlorination of water points and wash interventions in targeted health facilities by providing some IPCC materials. And of course, everything that is related to coordination and stakeholder engagement can be done And finally, which is usually the activities, the main activities are done and they are part of a project, of a start fund project, which would be emergency water trucking, everything that is related to hygiene and sanitation distribution. So it can be distribution of IPC materials, hand washing stations, kits, community cleanup and cash assistance. So there was some project, not that many actually, but some project that did some cash distribution or implementing cash for work programs. And finally, we did have some activities related to disease prevention and control, such as dengue kits, for example, or water quality testing kits and these kind of things. And finally, it would be related to infrastructure developments. So as I said, all this activity will of course depend on the needs and the type of crisis, but just to give you an overview of in 45 days, what type of activities are usually implemented for start funds. Next slide, please. Yeah, so case study, next slide. Yeah, I will just give a brief overview of one project that was done. It's the most recent one, which was in the Philippines. It was anticipation of disease outbreak. So just to give you an overview of the crisis, it was after a typhoon, which entered the Philippines, and it caused like severe damage on the island. There was loss of internet, of property, of source of potable water, and also on top of damaged house, there were also health facilities that were damaged. So there were an increasing risk for waterborne and arthropod-borne disease. So they decided to raise an anticipation alert. Next slide, please. So just to give you, it was a very interesting project, and it was a consortium led by Humanity and Inclusion, Relief International, and Médecins du Monde. And they assisted a total of 1,150 households. And as you can see, there will be activities at the individual and household level, facility level, and community and local authorities. So individual level can be hygiene kit distribution, awareness, cash for water, this kind of activities. While at the facility level, it will be dengue testing kits, IEC materials, training, and supplies distribution. While at the community, it would be like cash for work for community cleanup, advocacy, provision of sanitation supplies, for example. Next slide, please. And yeah, so just lesson learned that was shared by the agencies. And overall, what they said is that coordination and duplication and alignment is very key. Community consultation is also very important. They also managed to do some cost efficiency in the way they implemented the project, and they increase the coverage of the project. The timeliness is a key, and it's very important to have some quality work, basically. And finally, they had some, for example, unintended positive outcome, which was, for example, the training they've done allowed the people to have some accreditation and be accredited as health worker. So this is just key learnings. But of course, as I said, I will send you the link to the crisis response summaries that we have. And you can see for each project, for example, if you're more interested in just Ebola type of response, or a dengue type of response, or cholera type of response, it can be found on the website. But yeah, that's it from me.
Fantastic. Thank you so much, Emma. And yeah, please do go ahead and share the links in the chat so people can start accessing those. Emma, if I'm not wrong, you'll hopefully be able to stick around for most of the rest of the call. So if people have questions immediately, please do pop those into the chat as well, and hopefully Emma can respond. But for now, I think we'll move on to our next speaker to make sure we have time to hear from everyone today. So our next speaker is Tilly Alcaina. Tilly is a senior technical advisor at the Red Cross Red Crescent Climate Centre, and her portfolio of work includes co-leading the Anticipatory Action and Health Multi-Agency Working Group, which is hosted by the Anticipation Hub. She has over a decade of professional and academic research experience in climate change adaptation, public health, epidemiology, environmental health, disaster preparedness, and climate finance. In addition to this work, she's also completing her PhD at London School of Hygiene and Tropical Medicine on early warning systems for climate-sensitive infectious diseases. So a very impressive profile. Tilly, I think I'm handing over to you now to share your screen, so I'll just stop sharing and over to you. Thank you so much for joining us.
Thank you so much for inviting me and for inviting updates from the AA and Health Working Group. I'm just going to share my screen very quickly. Hopefully this looks good for everyone.
Yes, clear.
Perfect. Great. Thank you so much. And thank you so much for the introduction. So in the 20-ish minutes that I think I have, I'm going to quickly run over again the sort of concept of anticipatory action, just so that we're all on the same page, and really take a focus on the concepts and practice and approach that the multi-agency AA and Health Working Group is trying to advance within this community of practice of all of us that are trying very hard to work on anticipatory action for health. I'll take a focus on climate-sensitive infectious diseases because that is where we've advanced the most, and certainly most of the focus has thus far been, at least between the Red Cross Red Crescent movement, Médecins Sans Frontières, and OCHA, who are all part of the multi-agency working group. But to note, the multi-agency working group is totally open, and I'll share some details of joining if anyone on this call would like to join. And then I'll spend the majority of the time looking at these three approaches for anticipatory action for epidemics that reflect probably the state of the art in terms of concept and practice thus far, pulling out examples from across MSF, OCHA, as well as the Red Cross Red Crescent movement on how these have been applied and implemented to date. And then give a little bit more info on the working group for anyone that wants to join. Or at the end, I'll give the web link. But for now, so the AA and Health Working Group runs a series of webinars throughout the quarters, very much same as FOREWARN, and is an opportunity to exchange amongst all the different actors on what has been piloted, what is being tested, resources that are being developed, and really to try and build up this community of practice that is interested on anticipatory action and health, and to map as many of the ongoing efforts as possible so that we can keep track of what is going on. So as a recap, though I'm sure this is very, very familiar to all of us, anticipatory action are actions to prevent or mitigate the potential disaster impacts before a shock or before acute impacts are felt. And so the figure that I have here is a little epi curve, something that we'll see quite a lot. And those red lines on it are sort of at what point anticipatory action could still be considered anticipatory action. So it might be, and this would be in the ideal scenario, that you could indeed implement based on some kind of information that an outbreak might be likely or an increase in cases, and you could implement before this happens to try and prevent perhaps anything from happening in the first place. Or it might be another situation in which a number of cases have already occurred and you are acting very quickly to try and block an epidemic, an outbreak from extending any further, becoming any bigger. Or it could indeed be still actions in which quite a number of cases have occurred, but you're still trying to act as much as possible before sort of the epidemic peak has occurred, and certainly before there is a decrease in cases. And so that's where anticipatory action for epidemics and then also for other health concerns can be perhaps a little bit different from AA for natural hazards, where very often you are acting before the natural hazard has occurred. So that's something that we can talk about in questions at the end, perhaps to hear different people's perspectives, but is currently the thinking and certainly how it's being implemented so far. And once again, the key aspects of anticipatory action are really about the time factor. The actions, who will implement them, these are all defined in advance, and they are carried out in advance of the full impacts of the disaster or crisis. The aim is to prevent or mitigate the disaster impacts, and the methodology is that the actions are based on forecasts of when and where a hazard will occur. And the absolute key is this pre-agreed funding mechanism, which allows the action plans to be implemented once the forecast thresholds or consensus triggers are met. So yeah, just as a quick recap on what that looks like. And this is another schematic that we use quite often to show where anticipatory action sits. So it is absolutely not a replacement for disaster risk reduction. It sits within this at a very specific moment in time. And it is also not a replacement for preparedness. All of this is incredibly important and ongoing, and anticipatory action is just one of the tools that we can try and use to reduce and mitigate impacts as much as possible. When it comes to health, so for the working group, it is the working group AA and health, but within that we do consider nutrition, though a lot less work has been done on it thus far, communicable diseases, in which the majority of the work has been done, and then also non-communicable diseases such as mental health impacts, in which some discussions have been had, but a lot less of the sort of practical work has yet been fully conceptualized and implemented. And what I'm going to do today in this talk is focus a lot more on communicable diseases and specifically climate-sensitive infectious diseases. So climate-sensitive infectious diseases are a subcategory of infectious diseases for which we don't yet have a definitive list of what these diseases are necessarily. So you can't necessarily go to WHO and say, what are the climate-sensitive infectious diseases? And this is because disease development is quite complex. It involves climatic factors, land use change, globalization, migration, poverty, antimicrobial resistance, human behavior, the immune status of populations, control measures. All of these interacting factors lead towards the development of a disease or not, and an outbreak that might expand up into an epidemic or not. Often we're lacking sufficient data on the whole range of diseases in any of these sort of factors. And also these factors can mask each other's contribution to disease incidence and disease development in quite complex ways, which makes it very difficult to say for sure that this disease is climate sensitive and this one is not. So the way that we go about thinking it is that the relative influence that climatic variables, so temperature, precipitation, and humidity, have on disease ecology and transmission potential is high as compared to any of the other factors. And in general, the characteristics of climate-sensitive infectious diseases is that they show strong seasonality. They also have, they show strong interannual variation in incidence and distribution. So that might be associations with global climate phenomena like the El Niño Southern Oscillation or the Indian Ocean Dipole. And they're often geographically bounded within climate zones. So the meningitis belt in sub-Saharan Africa, in which you find the great majority of meningitis incidents, or dengue sort of bounded in the tropics as well. Some of the more famous climate-sensitive infectious diseases will be vector-borne diseases like malaria, dengue, which we're going to hear about, Zika, chikungunya, yellow fever, Rift Valley fever, cholera, typhoid, rotavirus, and other waterborne diseases like that. So there is general consensus on what some of them are, but once again, just to say that there's no definitive list that you can go and look up. Climate change is likely to aggravate over half of infectious diseases confronting humanity. And there's this really great paper which outlines all the direct, indirect, and cascading pathways by which climatic hazards can influence infectious disease incidence. And so this is quite a key paper to check out. So just very quickly, climate change is highly likely to influence climate-sensitive infectious diseases in ways that we can potentially quantify and predict, which is very, very important for us in the anticipatory action world. But it's also likely to have indirect and cascading influences on other infectious diseases, which might not be so evidently climate sensitive. And certainly how climate variability and climate change influence infectious disease is highly dependent on the country, on the type of disease, and also on any other sort of mitigating and control measures that are in place. So once again, to iterate that it's really, really important to always think of the context when developing up AA and health projects. We have tried to outline as much as possible, though I'm sure that this is absolutely the choir listening to this talk, of what the added value of anticipatory action for epidemics is. So we have quite a long list, which is great, and I'll just run through it pretty quick. So AA helps identify in advance when climatic or environmental conditions may be suitable for increased disease transmission in a particular region, country, or subnational part of the country. It helps identify in advance which regions might be mainly affected by a disease outbreak. So that can help in targeting and hotspot mapping and trying to figure out specifically, if you have limited resources, where might it make sense to allocate those resources. It's about improving the timeliness of actions on outbreaks by formalizing that trigger of the early or on-time action based on the surveillance data through those pre-agreed plans and funding. So that was that epi curve that I showed at the beginning, where anticipatory action is happening in advance of the peak of the epidemic curve. Helps to inform decisions about when and where to implement specific actions to contain the spread of an outbreak. Can improve early detection of cases through enhanced surveillance based on forecasting models. May be able to, depending on the approach that you've used for anticipatory action, for example, if you have incorporated any kind of mathematical modeling, provide an indication of the magnitude of the predicted epidemic curve. And also can help to identify changes in the spatial transmission patterns. So that might be that typically an outbreak does occur in a certain region of the country, but in fact, this year it looks likely that it would occur somewhere else. And then really importantly, can improve the coordination and clarification of responsibilities among relevant authorities and stakeholders as part of the development of those pre-agreed plans. And certainly enabling the mobilization and reducing the delay in response because of that pre-agreed financing, and helping to strengthen advocacy about epidemic risk and the importance of epidemic preparedness into national disaster plans. So now I move on to those three main approaches that we've sort of identified that helps the framing and the development of projects when you are trying to think of AA for epidemics. So the first one is actually still much more linked to hydrometeorological hazards. So it might be a flood or a drought, but in which you identify the health impacts of this hazard that would occur thereafter. So something that we have heard about that happens quite a lot. And you will conduct a number of health activities for the aftermath of the hydrometeorological hazard. But your trigger in your entry point is still to do with the hydrometeorological hazard itself. So if in a given context, you know that floods or cyclones have typically been linked with previous disease outbreaks, and you have pretty strong evidence to back this, then perhaps within an early action protocol or within any sort of formalized AA document that you have, that you could outline that there should be mitigating, so early actions that are to do with reducing the negative health impacts. An example, a very concrete example of this, is the EAP for cyclones developed by the Mozambique Red Cross Society, which aims to prevent waterborne illnesses in coastal communities as a result of cyclones. And the early actions in this framework include the distribution of chlorine tablets and buckets, as well as a lot of hygiene messaging and health promotion. And funding is based on the forecast of wind speeds of 120 kilometers per hour or above at cyclone's landfall, giving a lead time of about 72 hours before the landfall. So you can see that the triggering mechanism is still to do with the natural hazard, and it is not necessarily to do with the health outcome itself, but the actions is to do with the health outcome. And so this is just one approach that you can do, that we have mapped across the Red Cross Red Crescent movement, how many of our EAPs have these kind of health actions in them. And it is something that we really encourage all organizations to do as much as possible, so that we can see where EAPs could be improved. The second example is much more focused on the disease outcome itself, and involves the development of a sort of multi-stepped composite kind of triggering approach based on a combination of your surveillance data and also amplifying factors. So these are factors that you know contribute towards disease development and in a given area. And they could include, and a lot of the ones that we've looked at do include climatic factors, so temperature, rainfall or humidity, but may include things like population displacement or conflict, or the economy, also something happening to the economy, or delays in any sort of routine interventions. So you kind of build up a composite multi-trigger approach in which you might have a pre-trigger, which could indeed use something like a seasonal forecast, in which you can see this season coming up, there's likely to be above average rainfall, or there's likely to be higher temperatures followed by above average rainfall, which, if you're looking at vector-borne diseases, could suggest that mosquito populations could increase. That could be your pre-trigger. You could then have a first trigger, which is related to socioeconomic factors that are going on. So if there is population displacement, or if anything else contextually happens. And then a second trigger could be based on your surveillance data, where you see that the cases have increased, or you have one case and that's highly concerning, and it might be either in a neighboring country or a neighboring community from your target community, or in your target community itself. And how those different triggers overlap or interact is really, really context specific, and always totally depends on what makes sense there. And as your triggers become more and more certain, so certainly by the time that you've hit the surveillance data, that's when the majority of the actions might come about. But earlier on, for example, it might be sort of low or no cost actions, where you do some refresher training on the case definition of the disease of interest or something with volunteers or with whoever in the community. So we have two examples of this. One of them comes from the implemented AA for cholera in DRC, run by UN OCHA, UNICEF and partners. So they had a number of different scenarios, which were also linked with the triggering approaches, in which when those were met, they then released funding for life-saving wash and health activities. And so their scenarios 1 and 3 were based on observed epidata, so surveillance data, of the cholera cases surpassing a predefined threshold. And this was different whether it was in an endemic situation or a non-endemic situation, and that defined which scenarios applied to the different provinces. Because those increasing cases indicated a heightened risk level for a large outbreak, which would mean that absolutely, whilst the case has occurred, you're still trying to prevent the majority of the epidemic peak and save as many lives as possible. And then they also additionally had hydrometeorological hazards and other external shocks added into this to build up a composite indicator of different scenarios and different triggering thresholds that would kind of help you understand which actions are needed where. This is very similar also to the EAPs that are being developed across the Red Cross Red Crescent movement, also on cholera, where we'll once again combine epidemiological factors, so either suspected or confirmed cases in neighboring districts or countries, with other health indicators like malnutrition, and then environmental and social factors. So it might be population movement, or again, increased rainfall or flooding or drought conditions. And these come together to build up what will make sense in an EAP triggering scenario for the given country. And it would trigger, again, health and wash activities. And we currently have simplified EAPs being developed for cholera in Cameroon, Ethiopia, and Zambia, but they haven't yet been implemented as a UN OCHA one has been. And then the third and final approach is, and this one is the most challenging, where you would, if you have sufficient data, and it can be a very, very long time series of data that is needed, build up a mathematical model to try and predict outbreak risk. Substantial progress is being made in academia to combine climate and epidemiological data. So this is why we've had this focus on climate-sensitive infectious diseases in these mathematical models to predict the probability of a future outbreak. And it's never, these models are never able to predict with absolute certainty that an outbreak is going to happen, but rather they give likelihood statements of, based on this these set of climatic variables, it is likely that we might see an increase in cases at X lag period. There's this other great paper which has done a landscaping of all the different tools that are out there, so different mathematical models that exist out there. And of a list of 242, they found that only 37 had been operationalized. But of these 37, none of them have really been operationalized in the humanitarian context. So that's, again, something, a huge call for us to perhaps partner up a lot more with academics where it makes sense, where data is available, to try and build these up and use them as just one of our many tools to help improve our anticipatory action. MSF has piloted this approach in their malaria anticipation project in Jonglei State in South Sudan, in which they had a long enough time series of their own data to be able to build a model that uses epidata and climate and environmental indicators to then try and predict the weekly number of malaria positive patients in their OPD, their outpatient data. And this has been used now for the past 2 years, I believe, or at least 1 year of implementation, where it's helping them sort of plan in advance of what they need. And certainly trying to help them in their planning of their vector control and chemo prevention, and then also understand any increases in clinical capacity that they might need. And then also advocating for other actors to intervene and sharing information with communities who can implement community-led responses based on this mathematical model that helps them understand and forecast what is about to happen. So all of these are different approaches that we can use as in our toolbox of AA for epidemics, but also another really like low commitment before you're perhaps fully embarking on making an early action protocol or equivalents, can simply be making really good seasonal emergency calendars where you can track across in a different country or in a specific region what the different kind of weather events are and when they maybe peak more often seasonally. You can have a look at extreme weather and put this into a calendar to try and see when there are peaks in extreme weather events. Again, you could add in food security elements, anything to do with displacement, and then very critically, the sort of seasonal trends and patterns that you typically see for the infectious diseases that you're interested in, and put all this together in a seasonal calendar and a seasonal emergency calendar, something that we're very, very used to in the humanitarian sector, but that can help you just engender that anticipatory mindset, maybe on your journey towards building up full AA for epidemics or for other health impacts, EAPs or frameworks or equivalent. So that has been quite a speedy run through. We have a working paper that we hope to be able to share soon, which outlines all of these different concepts. And once again, if you would like to join the Anticipatory Action and Health Working Group, which is hosted by the Anticipation Hub, please do, and I can share this link in the chat as well. Thanks so much for having us share this information, and it's been a real pleasure on behalf of the co-leads. Thank you so much.
Thank you so much, Tilly, for such a comprehensive overview of those 3 different approaches. I know it's difficult in the short time, so yeah, thank you for that. And if you're happy, I think there's a lot of interest in the slides being shared, so we'll send those around afterward for sure. We do have a couple more minutes, so I don't know if there are any immediate questions for Tilly. I didn't see any come up in the chat as we were going, but if anybody has any, feel free to raise your hand and we can come to you. Otherwise, Tilly, if you're okay to stay on the line, we have a bit of time at the end as well, so we can always move to the next speaker and then come back. But thank you so much. That was a really fantastic presentation, so thank you for that. So I'm handing over now to my colleague Ashraf ul Haq, who is going to introduce our next speaker. Ashraf is the FOREWARN coordinator in Bangladesh. Ashraf, over to you.
Thank you very much, Millie, and I think I'm audible. Yeah. So now I will be handing it over to our FOREWARN expert in Bangladesh. His name is Atik Hassan. By training, he's a medical anthropologist and currently working as senior program manager at Environmental Health and WASH Unit under Health System and Population Studies Division at ICDDRB Bangladesh. His areas of interest are in digital epidemiology, connecting technology to health, climate change impact on health, and he has broad expertise in monitoring and evaluation, mixed method research and GIS for sure. And now welcoming our foreign expert, Atik Hassan. Over to you.
Thank you so much, Ashraf. Can you hear me?
Yes, fine. You are.
And can
fine.
you see me? I cannot see
Yes.
myself though.
Yeah, we can see you as well. Thank you.
Okay. Okay. So thank you, everyone. Can I share my screen, or Ashraf, you will share the PowerPoint presentation?
Miri, I think. Okay, yeah. Now, I think you can share your screen as well.
Okay. Okay. Thank you so much. Thank you so much. So, can you see my screen?
Yes, it's fine.
Thank you. Thank you. Okay, so my presentation will be possible dengue control strategy in Bangladesh, a technology-based approach. And Tilly already gave a very concrete background, theoretical understanding on how epidemiology works. So she makes my work much easier to make other people to understand. So I'll use quite a lot of I and me. My apologies for using those terms at the very beginning. So let me start then. Okay. So dengue is quite a big problem nowadays in Bangladesh. It started in 2000 and it was mainly concentrated around and surrounding area of Dhaka City Corporation area. But in 2019, it was a very massive outbreak, quite a big spike. And some of my friends and their relatives, they're informing us that people are getting fever and they're going to hospital within 2 days, they are dying. So as a student of medical anthropology, I was trying to understand what's going on. And then I asked people to voluntarily share their data. So before we go into that slide, let me show you the graphs, what is happening. So you can see since 2000, there was quite a lot of patients, but not like 2009. Like it was more than 100,000. And in 2013, it's already crossed 300,000 and 1,665 deaths. So what are these numbers is actually very small tip of the iceberg, because 80% of the cases can be asymptomatic or not reported. Only 20% get the dengue fever, which is symptomatic, and 1% who are getting to the hospital with dengue hemorrhagic fever or dengue shock syndrome. We are getting information only for those patients. So that number, 300,000, is just from the 1%. So what are causing this dengue fever outbreak in Bangladesh and any other parts of the world is there is 4 different serotypes. So one after another is coming. The climate change, heavy rainfall, urbanization. Already Tilly said a lot about this. And the thing is, there was a seasonality pattern in dengue fever in Bangladesh, usually in the rainy season, kind of April to July, August, or September. But this year, it's still continuing, like day before you started. More than 500 patients admitted to the hospital with critical condition, and then more than 10 patients died maybe day before you started. So there is no seasonality pattern because of the climate change. And these are all only from the hospital-based data. Those are admitted to the hospital. And we have around 6,000 hospitals in Bangladesh. This data is only coming from the maybe 50 or 60 major hospitals in Dhaka and from outside Dhaka. So again, this is a very small number that are capturing in this database. But before we go further deep, we need to know how these things are happening, so how these are transmitting.
By default, dengue mosquito is not carrying the virus. When some person is infected, if the mosquito bite that person, that mosquito also get infected. And then the mosquito, if bite another person, that person also getting infected. So this cycle is going on. But if we can break the cycle in any point of time, like either stopping mosquito to biting that person, protecting that person to bite the mosquito, we can break the chain. So what happened in 2019, that I said that lots of my friends, they say their family members and other known people are going to hospital with the fever, and within 2 days, people are getting dead. So I was quite worried that time, and I asked people to share their location. So people voluntarily share infected patients' data through Facebook. I have created an online form to provide their data. And after getting their data, I plotted them in the map, and this pattern appeared. Then I was trying to find out what's going on. So then I collected this hotspots data from Ministry of Health and City Corporation. So the orange area you are seeing are the hotspots they have identified. But when I'm matching those two different layers, they didn't actually match. And for example, this part, there is no patients. On the other hand, here, lots of patients where they didn't identify this place as a hotspot. So I further zoom in of the patient's location and identify that many hospitals around this patient's location. So I have visited 2 hospitals, and I have found that people are not under the mosquito net. So I tried to talk to the media and write the newspaper that all the patients in the hospital should be kept under the mosquito net. Otherwise, those people are transmitting the virus surrounding the hospital area. And again, there are 2 city corporations. This is another challenge. So we have North City Corporation, DNCC, and Dhaka South City Corporation, which is DSCC. So DNCC said there is no mosquito in our area. Mosquitoes are coming from the south, and south saying that those are coming from the north. So there is a lack of very much, collaboration, and people are blaming each other. Ministry of Health saying this is the work for the local government, but local government said this is the work for the Ministry of Health. So there is a massive communication gap and coordination gap. So what they are doing, the map you have seen before, that the hotspots, they are actually doing the traditional Aedes larva survey. So hotspots, those hotspots are basically Aedes hotspots, not the dengue hotspots. And for identifying dengue hotspots, we need to identify the patients. So possible gaps, we have identified the lack of patient-based surveillance that is not available, lack of coordination and communication between different stakeholders, and knowing the asymptomatic nature of the primary dengue infection. Bangladesh existing dengue reporting system based on data from the selected public and private hospitals, admission records, it is not clearly appropriate for the preventing of the disease. So what needs to be done is to protecting the infected individuals from being bitten by the Aedes mosquito, as we have said in the beginning, that there is a cycle. All the Aedes mosquitoes are not by default carrying the virus. They need to bite someone who is already infected. I mean, human person. So if we can make the barrier, that might prevent the transmission, and quickly identifying the dengue hotspots, and it should be real time, and immediately that data can be transmitted to the city corporation so that they can take immediate action and take measures to control the mosquito surrounding the patient. And another part is to mobilize the social working group in the locality so that they can ensure the cleanliness surrounding the the patient's area, and make sure the patient is under the mosquito net. So this was our idea, and as we have said that there are lots of stakeholders need to be engaged, lots of system need to be done, and it requires quite a lot of money, a lot of training. But I would like to thank FOREWARN and Eastern Network Bangladesh that from that idea, we have started some sort of pilot project. The idea was to collect all the patient data, because the map I have shown at the beginning, that I manually collected those data and individually plot those data points and map them. But when it is more than 100,000 or 300,000 or maybe 100,000, this should be automatically connected. So the idea is to connect all the hospitals and diagnostic centers connected through the API, those who are positive. The system can be identify and map those places and identify hotspots and transmit those data to the city corporation, who are responsible for cleaning and killing the mosquitoes. That way, it can be we can take under control of controlling the dengue. We cannot eradicate it, but still we can try some way to control the dengue outbreak. So what we did, we make a patient surveillance with the support of FOREWARN. So we took 4 wards from Dhaka North City Corporation, and with the help of the local NGO SIP, they mobilized to those 4 wards in the Dhaka North City Corporation area. They collaborated with the hospital and DNCC. They prepared the institutes, and at the same time, mass awareness and policy advocacy also done by FOREWARN Bangladesh, and SIP field worker engaged community at the same time. So they put a sticker with the hotline with the households where the patients are living, and following those households by cleaning and in the affected cluster. They also larvicide and eradicate in the household with the help of city corporation, and they are doing on their own at the same time. And there is an interesting pattern of the Aedes mosquito that in their lifetime, they are not flying more than 450-meter radius. So they try to clean within 400-meter radius if they find any patient. And after the 4 months project, it was a very short duration and short-term project. So we found that in our intervention area, we found only 13 patients, and in the comparison area, we have 25 patients. So that intervention area and both comparison and intervention area, they have identified the patient, but in the intervention area, they mobilize with the community, they clean those households, they make aware to those people, and eventually the comparison area, they didn't do that, and the result was almost half of the number of patients. So these are the location of the patients, and that's it. So we have planned, if we get the bigger fund, and this is not concentrated only on the Dhaka city, so we need to make it to scale up not only in the Dhaka city but also over the Bangladesh. So thank you so much. If you have any questions, please let me know.
Thank you so much, Atik. I think there is a question in the chat from Niraj. So Niraj, I don't know if you want to come off mute and ask your question.
Okay.
Yes, thank you very much for the great presentation. I was just curious, well, first of all, kudos to you to establish the surveillance system, the dengue surveillance system. We also recently raised an alert for dengue, and it was a response alert. Although we targeted an area where there was already a high number of cases for dengue, we also responded to neighboring areas thinking that the dengue might be spread out to these other areas as well. So in terms of the locations that you got from the people, which is I feel is like a citizen science concept, that you're getting coordinates from the people that are affected. how do you incentivize people to share their locations? Because it's a disease that people might not be willing to share, given, and there might be some issues with regards to the data privacy issues and so on. So I was wondering, how do you keep them incentivized to share this location so that we can map these affected communities properly? Thanks.
Thank you so much. As I said, there was a panic in 2019. So people are dying everywhere. There is no bed in the hospital. So I was voluntarily asked people to share their location because everyone was panicked and scared. And I was fortunate because all the social media and news media, they kind of make me kind of viral, and they promote me to share their location. So that was how people providing their information. Does it make sense to you?
Yes, it does. So, from your own words, if you were to do something similar in the upcoming dengue season, let's say,
Okay,
in anticipation of dengue, not in the response side of dengue, then do you think it would work as much?
I don't know about you're from Nepal, right?
Yes, yes.
Okay, so in Bangladesh, we have a law. So any disease which can spread out, any contagious or infectious disease, they are bound to report their location for the sake of controlling. If you can consider COVID-19, it's not about the privacy, it's about the safety of the people. So in some cases, you need to trade off some places. So we are not sharing. We are not saying that this is the location of that particular patient. We are just pointing out that particular location. So no other information shared. So in this way, maybe people may be interested, because if you tell them that we are not sharing your name or any other detail except your particular location, because it's not only about that particular person, because it's already also about that locality and the surroundings area. So for not only for him, but also or her, it's also for her or his family and the locality where he is living. For the safety of their own, they need to share their location. That's what I understand. Sorry.
Great.
I cannot hear anyone.
No, that's okay. Thank you very much. Thank you. I can't see any other questions in the chat, but if anybody else does have a question, please do feel free to raise your hand. And we can also come back again, as I say, towards the end of the call with a bit more of a wider discussion. So thank you so much, Atik, for that presentation. It was great to hear about the work that you've been doing in Bangladesh on dengue. Thank you very much.
Welcome. Thank you.
We'll move on now, just quickly, onto our final presentation of the day. So just to reshare my screen quickly. So our last presentation is from colleagues at CAFOD. So we'll be hearing from Alexis Boyer. Apologies if that's a mispronunciation there, who is the humanitarian fundraising team lead at CAFOD. And if I understand rightly, I think Christopher Tusimi, who couldn't join us today, but is a program officer who also contributed to the presentation and the implementation of the alert. So Alexis is going to talk about CAFOD's work in relation to the Start Fund Alert 661, so the anticipation of Ebola in Uganda, which was activated for 250,000 GBP in November last year. Alexis, over to you. And if you prefer to share your slides yourself, just let me know.
No, if you don't mind using the slides that you have, that would be great, because I have notes in mine. And so, yeah, if that works for you, to just use yours.
Absolutely, no problem.
Great. Thank you very much. Good morning, good afternoon, everyone. As Millie said, my name's Alexis Boyer. I'm the humanitarian funding team leader at CAFOD, based in London. And as she said, unfortunately, my colleague Christopher, who's our program officer in Uganda, is on leave today, starting his holidays off early. So unfortunately, you just get me. And hopefully I can answer any questions you have about this program after I present. So if you could please, thank you very much. So yes, as you know, this was a start-funded anticipation program for Ebola prevention in northern and Karamoja regions in Uganda. CAFOD does very little implementation directly. We primarily work through local partners. So in this case, Caritas Gulu, Kotido, and Moroto. And we worked across 11 districts in northern Uganda. And as Millie said, this started this time last year. We were just getting ready to wrap up. We reached about 500,000 beneficiaries, both direct and indirect, with a total budget of £215,000. We were able to start implementation almost immediately, given that we do work through local partners and they were well positioned to respond to the needs of the community as well as the anticipated needs of the community as we were kind of watching the Ebola infection spread into, not quite into northern Uganda. I'll get to that part later, but as we kind of watched the number of infections grow and watched other parts of Uganda kind of deal with the infection as it spread. Our activities primarily focused around WASH, health, and awareness raising. Kind of before I get into expected results and what was actually achieved, I think it's important to mention that as we started implementing, we did make some changes in our project location. For example, we extended into more districts around Gulu because they had a past history of Ebola outbreak, particularly in 2000 and 2001, and its location near the border with South Sudan also made it kind of a key transmission point. Additionally, we also extended into Abim district as well, given its space on the border. And we just wanted to make sure we were really targeting the communities that were at a particularly heightened risk and potentially more vulnerable to transmission, giving that kind of cross-border location. All right, if you could, thank you. So as I stated, we kind of really focused on WASH, health, and awareness raising. Our primary expected results was ensuring that communities didn't become infected with the Ebola virus, but that communities also understood what the key symptoms were, how to prevent transmission, and I think kind of most crucially, what to do if they suspected they had received the virus, or if they were worried about a family member or a friend, who to reach out to within the community, whether village health teams or community leaders. So to do this, we worked primarily through existing community structures. We worked closely with existing village health teams, local and religious leaders, as well as the existing government task force that had been set up to prevent the transmission of Ebola, particularly focusing on reducing and preventing transmission to the most vulnerable households. Okay. So kind of the key activities, we ended up sharing more than 50,000 IEC materials to community members across the 11 target district. We worked very closely with the existing Ebola task force members to kind of streamline communication and key messages to ensure that the communities we were working in were hearing the same thing and kind of reducing misinformation. We also helped the task force kind of coordinate themselves and setting up district meetings to kind of make sure the messaging and the activities in those different districts were targeted and specific. We also worked closely with over 10 radio stations to produce more than 30 different talk shows and messages, sharing, the key parts of raising awareness for Ebola, how to prevent it, what to do if you think you have it, what are the key symptoms. And then, of course, these radio shows also provided a lot of good, kind of basic good health and hygiene messages. We distributed PPE to health workers to make them feel safer and more secure while they were providing care. Also training 850 health workers on signs and symptoms, duty of care, health workers' protections, just kind of raising that overall community awareness of what the virus looks like and how to prevent it. Okay. As I said, yeah, working very closely with existing structures, local councils, religious leaders, and traditional healers, kind of those basic, day-to-day things that need to happen in this kind of response, providing fuel and allowances and cell airtime so that people can communicate with each other across the 11 districts. And then additionally, we provided hand washing stations. We initially hoped to provide about 400, but given the variations in price, we were able to provide around 800 hand washing facilities. Initially, these were going to be placed in schools, but because of schools closing early, because of the outbreak and because of the Christmas holidays, we eventually decided to shift these to other high traffic areas like markets, places of worship, police stations, things of that nature. And I think it's kind of important to mention, as this was an anticipation program, the crisis didn't occur as expected. However, by December 13th of last year, there were more than 142 cases across 9 other districts, with 55 deaths and more than 87 recovered patients. So while it was quite fortunate that it didn't move into the northern and Karamoja regions where CAFOD and its partners were working, it did have a rather devastating effects in the districts where it had spread before kind of the Ministry of Health's response really kind of curbed the transmission. I think we kind of attribute the lack of the crisis occurring in the target areas. I think we would like to say because of CAFOD and our partners' efforts, but I think there really was quite a lot of existing infrastructure and investments because of past outbreaks. I think the government of Uganda's Ministry of Health had a lot of great IEC material readily available that was either already printed and can be distributed immediately, or kind of digital copies that you could just print out and then distribute. And then additionally, there were some kind of pre-existing early warning systems and some work around DRR that really, helped curb what could have been a potentially devastating outbreak in Karamoja and the northern regions. Okay, so thinking about what worked well, as I said, we did, I think, in any kind of response, particularly around a disease outbreak, you really do have to work within those local government structures and engage with the district ministries of health. And because of that, we were able to receive the existing IEC materials already. So once we had those digital copies, we could just print and start distributing, which I think is why our indirect reach was so high, because we put these materials in really high traffic areas where people would be most likely to be shaking hands and engaging with others, around markets and churches, for example. So we were able to kind of lean into those existing investments and those existing structures to implement quickly. Working through local partners is something that CAFOD believes in quite strongly. We really do think, local partners know their communities the best. They're able to respond most quickly, most efficiently. And we think in this case, that's really how it worked out, working with Caritas Gulu, Caritas Moroto, and Caritas Cotito, who were our long-term partners of CAFOD. So we had kind of developed this really strong partnership structure that we think worked quite well. And I think this is kind of to bullet 3 around the commitment of the project teams. As we know, a 45-day response is incredibly quick, having to start up within 7 days. And especially as this started on November 13th or 16th and ended December 28th, we really were kind of in that prime holiday season. And our partners and Chris were really quite dedicated to make sure they were working over the weekends to complete activities. Working with the Ministry of Health, really streamlining the guidance we were providing, so there was no kind of mixed messaging. And then thinking about those procurement processes, especially around PPE, to make sure we were both following appropriate procurement processes, but also making sure we were reaching health workers and those most vulnerable as quickly as possible. Also, I think scheduling training activities at times that best suit the community, we found that to be really helpful, as we didn't want to disrupt people's lives any more than we had to. Okay, this is kind of just general results to give you an idea of the overall reach. As I mentioned, we reached 500,000 people with various IEC materials, including the paper materials I mentioned, but also radio, road, market shows. We supported 347 health workers and trained them as well on Ebola-specific material. We trained more than 1,875 village health teams, 200 chairpersons, 100 religious leaders, and 8 traditional healers in how to prevent and recognize the symptoms of Ebola. As I mentioned, we work with the Ebola task forces, in particular to facilitate greater coordination across the 11 districts CAFOD and its partners were working in. And then, as I said, provided more than 800 hand washing stations that are still there. After the program ended, those hand washing stations were left behind so they could continue to be used by the communities, to further promote good hand washing techniques and prevent, further transmission of other diseases as well. What didn't work well? So obviously some delays around local government officials in providing information. I think as we kind of watched the transmission of the disease across the country, there was some delay in just local government officials speaking to each other about transmission rates, death rates, recovery rates, things like that. Really high inflation and the increasing commodity prices, I think, required us to adapt a little bit as the program was underway. And then finally, this was the first time our partners were doing a start response, whether it's response or anticipation. I see your question, Chris. I'll come back to you. This was a very new type of program for them. So I think our M&E systems just weren't quite ready to handle kind of rapid emergency funding. And I think in kind of the reporting period, we worked quite closely with our partners to help them, collect the data that we needed to report to start, but also to understand those numbers as well. I think what would we have done differently? I don't think so much around kind of our key activities or our key target locations would have changed, but I think if maybe we were doing this again, or if it was a longer term kind of program, we maybe would have trained ambulance drivers and school teachers to make them feel more comfortable in relaying information, kind of trainers of trainers situation, school teachers engaging with pupils on good hygiene in general, train more village health teams, not just around Ebola symptoms and treatment and prevention, but also to kind of help manage the community and social aspect of Ebola and its impact on community cohesion and kind of psychological first aid. Integrate Ebola testing with other types of testing like COVID-19, and then maybe thinking about how to do trainings to deal with some of the impacts on business and movement being restricted if a full lockdown is called by the government, and how best to help people cope with those kind of rapid social changes. Yeah, and that's mine and Chris's contact information. So please, I'm happy to answer any questions now, but if anything else comes up or you're having a think later in the week, please don't hesitate to reach out. And then I think, Chris, your question was around how important do we think engaging with religious leaders was. I think in this case, because we were working with Caritas partners and diocesan level partners, we think it was quite important because the communities that we were working in were utilizing the church as kind of a collective community meeting point. So we think kind of getting the buy-in of religious leaders and training them on the symptoms of Ebola, how to prevent it so that they could then, reach out to their community as respected leaders to kind of share that information, reduce misinformation, and kind of ensure that everyone was on the same page about the seriousness and potential severity of the outbreak if it had, kind of jumped those district borders into Karamoja and northern Uganda.
Thank you so much, Alexis. Chris, I don't know if you want to come back at all on that. I know you've just shared some experience from Tier Fund as well. I don't know if you wanted to come off mute and follow up at all.
Not really, just I guess echoing those points. I think you know, whatever work we do always sits within belief systems, and so how people respond to, you know, disaster hazards and how they kind of recover from them are very much influenced by their faith and belief systems. And so I think it's important for, you know, all of us as agencies to really understand and work with, you know, who holds the power and influence in those systems, because people very much see the world through them and face whatever disasters, you know, with those kind of faith lenses, whatever the faith is. So I think it's just a key influence, and we can really make a huge difference about who people listen to. They might not listen to governments, but they will very often listen to their faith or religious leaders.
Yeah, I think that very much aligns with kind of what we learned in this experience working at the diocesan and district levels. Thank you, everyone.
Thank you so much, Alexis, for that insight into into CAFOD and your partners' work in Uganda. I think it was particularly interesting that you mentioned, you know, the outbreak didn't occur as expected, and I think that's a really key point around you know, anticipation and how we work in that. I think it also links, and I will open the floor to questions in a moment more broadly, but to Clara's question in the chat around you know, as practitioners, we understand very clearly the benefits of doing anticipatory action, but the challenge that we face often is convincing donors that actions can be attributed to that outcomes can be attributed to actions that were taken. Alexis, I don't know if you have any insight on that. I can just mention from the START network side, we obviously, as you said, Clara, FCDO do a lot of work around anticipation. We also have GFFO as a donor, so the German Federal Foreign Office. They support both our disaster risk financing work as well as the START fund with anticipatory action priority. But I think, again, the challenge that we face is really about this evidence-based question, particularly with health, being able to show that causal link, which is really challenging. So Alexis, yeah, I don't know if you have a response to that at all. Sorry to put you on the spot there.
No, it's okay. This was actually the first anticipation program I think that CAFOD had implemented. So it was, while we're quite familiar with START response, this was our first time utilizing this mechanism specifically. And I think we weren't quite sure what to expect. You know, I think at the end of the program, when Chris and I were doing the reporting, he was like, this didn't happen as we had thought it would when we raised the alert. And I was like, well, it shouldn't be a problem because START has kind of a no regrets approach to anticipatory action. And I think that's really kind of what we had in our minds as we were working on the proposal, and then during implementation and reporting, was it's anticipatory. It's meant to get out in front of something that, you know, past experience or current epidemiological data says could happen and could be quite devastating. But if we can do what we think is best, what are the evidence-based approaches in curbing Ebola, then it doesn't matter if the crisis didn't happen, because that was the whole point. The whole point was to have a no regrets program to keep this from happening. And I think keeping that in mind, and I think START does a good job too of reminding you in all your emails that this is no regrets, that was quite key. And I think all anticipatory response needs to keep that in mind, whether it's disease or flood or El Nino related flood, especially if you know it's going to happen, then you can get out in front of it. But yeah, it's money incredibly well spent, especially in a situation like in Uganda.
Fantastic. Thanks so much, Alexis. Yeah, I mean, perfectly put, to be honest, in terms of START's funding. Yeah, that no regrets side of things I think is really important. So thank you for that. I will just ask Emma Kazu, I don't know if you have any reflections on kind of the evidence side of things and how we evidence that link between the actions that were taken and the impacts of a project.
Yeah, I think I will echo what Alexia was saying on the no regret policy. From my experience, it's something very important for donors and something that really reassure them on investing on anticipatory action, to know that in case of lower impact, the money can be returned. Also, I think we discussed maybe previously in the previous FOREWARN event, And I know it's an endless question of how do we demonstrate value for money, and it's a big question that I think it's one of the priority as well for the evidence and learning team for next year. But as it's hard to find counterfactual, or it's hard to demonstrate what could have been the cost if it was a response, if you don't have a counterfactual or historical data, it can be quite complicated. The way we do it is usually we'll ask questions around the logistic and procurement, because there are easy stuff you can demonstrate that it would be cheaper. So you can always try to demonstrate how the operational costs will be lower, and some things that can be used to convince the donors. But once again, we don't have, it's a very tough question and there's no like a correct answer, but I think it's something we're all aware of and working on.
Great, thanks, Emma. Tilly, I can see you've also responded kind of along similar lines in terms of this being quite a priority for next year. I don't know if you want to talk any more about the the evaluations that might be planned for health with the working group next year.
Thanks so much. Yeah, so the co-leads of the working group, so UNOCHA, MSF, GRC and IFRC and myself from Climate Centre all met up in London last week. And these absolutely came out as like our top two for working on next year. If we're really focusing on the scaling up of anticipatory action, then the shortfall in financing of AA is a huge one. I mean, so the Red Cross Red Crescent movement is slightly unique in our access to the DREF funding, and then likewise for the UN movement, the SURF funding, and then here START Network. But there is still this huge gap in actually how much is ever spent. I think the Centre for Disaster Protection, CPD, based in London, did a really great analysis. I'll have to try and find it. And I know that this is being recorded, so I'm really worried about getting the numbers wrong. But it was something like less than 0.5% is going to AA of all humanitarian funding. And then within that, it's almost impossible to find out like how much is actually going towards health. But you can, that scale of like, it's tiny. And so that's a huge thing, finding out where we can access more financing. And then I guess in those approaches and from everything that we've heard so far, so strengthening the health components in the EAPs that exist for flooding or drought, like that's something that we can, for sure, in the Red Cross Red Crescent movement, when there's good evidence, look through and see how we can strengthen that. These excellent examples here on dengue in Bangladesh and then CAFOD with Ebola are really great of everything that AA can just do to strengthen up and to get more financing, more evidence basically on all of this. And so what we are, I guess, a little bit planning is to be able to map really well everything that is ongoing, to be able to bring this body of evidence to donors, grateful to Germans and to FCDO, those that are coming out, but then also others that are slightly less convinced as of yet, show this great body of evidence. But the evaluations, and I don't have an answer for that yet, is definitely something, because we want to be able to say where it does work, and if it doesn't work, be honest about it, and that's totally fine. And to show where and what works and what doesn't. So just again, a call out to everyone, please do, it would be great to have discussions more here on evaluations, how they could look, what needs to be incorporated, because it'll help us strengthen our programs as well. If we know what we would evaluate them against and what is a quality program that we would consider, then we can help make sure that that's embedded from the beginning. So yes, please, can we just have lots of conversations about this in 2024 and beyond? Thank you.
Fantastic, thanks Tilly, and don't worry about getting those numbers wrong, that's absolutely fine. I don't think anyone will hold that against you. I think START Network did a similar piece of work, it was START Network with ODI, I think, on that analysis of anticipatory funding, again, not broken down by sector or by kind of hazard, but maybe, I don't know if someone from START could maybe pull out that link and pop it into the chat, we have that as well, so maybe it's a similar report, but always interesting to see the potential for anticipatory action funding. Clara, I don't know if that helps answer your question slightly. If you're still on the call, I don't know if you are able to come off mute and I don't know. Yeah, go ahead.
Hi, all. Yeah, no, it more or less answers the question. In addition to, really interested in the evaluation pieces and how to kind of push that conversation forward. Yeah, obviously that it's a big thematic area for a lot of donors. But yeah, actually kind of translating that into action is the challenge. But yeah, really interested in all the kind of pieces, moving parts around this. And yeah, looking forward to remain engaged on it. Thanks.
Great, thank you very much. I'd just like to open now and see, I mean, if anybody else would like to come in on experiences with, evidencing anticipatory action for health, please do feel free. Otherwise, if there are specific questions around Alexis's presentation, if anybody would like to, I think we've caught all the ones in the chat, but if there are any others, please do raise your hand now or post in the chat. Otherwise, I think we can say another thank you to Alexis for the presentation. That was really interesting to have that insight and to understand that kind of embedded approach to anticipating Ebola. And I'd also just like to open if there are any questions sort of more widely on what we've heard today. I haven't seen any in the chat. Mark, yeah, hi, please go ahead.
Thank you, Millie. Hello, everyone. Apology, I'm joining a little late. And I'm just going to place a piece of work that we established a while back, which essentially speaks to an open scientific method that healthsites.io and others have established. And that is the approach that I think we have available to us. And one of the benefits that health sites and the OpenStreetMap community brings is this missing maps focus on OpenStreetMap data. So we have a base that everyone has access to. And as you may know, Health Sites is building this baseline of health facility data with OpenStreetMap. So the updates are shared for programs in the future, and the updates of this baseline health facility data continue to improve. So one is able to establish this empirical method of open science and human-centered design, where we are trying to measure the impact with SDG indicators. What's the improvement on maternal health indicators, for instance, as a result of improved data quality? And so this campaign structure that we've established and presented at the State of the Map Science Conference this year is an invitation to everyone on the call to collaborate and improve on. We have our building blocks, which are essentially providing a building block that we can build upon and iterate with. And the user stories and the human-centered design has the same approach. Where are the priorities? What should we be focusing on? How do we support the data to improve those outcomes? So I'll share another link to that methodology. And my point that I wanted to make was, there's an opportunity to focus on the open scientific method, and out of that can come business cases. What's the business case for an accurate master facility list? Particularly if you think in the context of a vaccination rollout campaign. Where two hospitals are, and you try and do the vaccination rollout campaign, most of the people are not going to get the vaccines, and your cost to the Ministry of Health is going to be X. If you know where all the facilities are and which have electricity, the cost is Y. That's the business case. So that's a piece of work that we engaged in and have had conversations with the ODI in this regard, and I'd love to build on that with this group. Over. Thank you, Millie.
Thanks so much, Mark. Yeah, and I can see that you've posted the piece of research there in the chat, and I'm sure you'll post the other link as well. And please, people feel free to reach out directly to Mark on this piece of work, which is really interesting around mapping health facilities. A question in the chat from Niraj. Is there an EAP for dengue? I think possibly Tilly, you might be best placed to answer this one in terms of, I guess just with the terminology of EAP. Over to you.
Yeah, I was just writing. So as far as I'm aware, I really hope that I'm not incorrect, not a implemented one. I believe that there are ongoing discussions, and colleagues at 510 within the Red Cross Red Crescent movement have been working on an IBF platform for dengue in the Philippines, but this was not operationalized yet into an EAP as far as I understand. I'm going to double check, but I'm pretty sure that we have no EAPs or simplified EAPs yet for any of the infectious diseases, and our closest ones are going to be the SEAP, the simplified EAP for cholera in Cameroon, and I'll have to check back the 3 countries that I mentioned before. But yes, as soon as we do have anything, we would happily share.
Thanks so much, Tilly, and I guess they can probably be found on the Anticipation Hub website as well.
Yes.
Great, thank you for that. Ella, yes, over to you.
Great, thanks, Millie. And thank you to all the speakers. It was really interesting presentations, and I feel health is such a cross-cutting hazard risk. As it's been mentioned, it's so kind of linked and embedded into other hazards as well. So it's been super interesting to hear from the speakers. I have a question which I think probably Tilly, you may be able to answer, but if anybody else can share reflections, please do jump in. But I think it's something that's come, I should introduce myself. I'm the Technical Analysis Advisor at Start Network, by the way. Hello, everyone. And it's come up a fair bit amongst our members, and we've seen a few alerts that recently have been related to the ongoing El Nino phenomena. And as we have seen recently, forecasts are suggesting that the El Nino will likely persist into the new year. And we know from historical El Nino years that there's been links to disease outbreaks, or rather that El Nino conditions very much can lend a hand to kind of ideal, for example, breeding environments for mosquitoes. And I was just wondering if there are kind of any current examples in the working group or discussions or reflections that can be shared around taking action based on El Nino forecasts. Thank you.
Shall I go first? What a great question. So yes, there are a number of great research groups working with El Nino forecasts and trying to sort of produce tools that might be useful to help public health authorities as well as humanitarians act in advance. And I would certainly say, when it comes to those actions in areas that we know that are very well teleconnected with El Nino, so there are some great maps that you can find, and I can share them in the link from IRI and from others, which kind of show areas that are highly teleconnected, meaning that they do show strong impacts of either flooding or drought, depending which part of the world they're in during El Nino and also La Nina. And they show which months they're more likely to occur in. So those can sort of act as a basis a little bit. But then there's also a bunch of great research that shows that whether or not disease develops afterwards is pretty complex. There was this great paper by Asaf Ainyambe on those connections in the 2014 to 16 El Nino event, and then the disease and an increase in disease outbreaks. So all these resources we will happily share, and those partners, academic partners that are working on these almost like El Nino briefs to some extent, a lot in the Caribbean and Latin America, where they're being able to help for, like you mentioned, the vector-borne diseases, suggest if there is going to be ecological suitability for the vectors in advance and whether there could be an increase in cases. So I will try and connect, or I'll share the resources afterwards with Ella and Millie, and then hopefully that can be spread out with everyone else on this group as well to help us. But it's something that we are very, very interested in trying to understand better. I know that MSF via Leo Tremblay is also looking at this very strongly. And there are a couple, again, I'll try and see whether we can share them, sort of El Nino briefs as well, to suggest what we could be seeing in the coming few months and what that could mean in terms of health impacts. So yeah, definitely something that needs even further study and further conversation amongst us all to be able to make sure that we're making the best use of all the climate information that is out there, and then being able to put in place actions. And I would definitely advocate again in that kind of when I mentioned that composite trigger of where your pre-triggers, which for example could be something to do with the El Nino that we know is going to continue on into the new year. Those again can be strengthening of the health messaging, the hygiene promotion, all the kind of not super high costly actions that can be done, in which we're just reminding communities again via either the faith leaders or whichever leaders make most sense, and community-based networks to improve knowledge of the case definition, of being able to recognize symptoms, of upending again all the good epidemic prevention, but upending any uncovered storage containers to prevent larval breeding, mosquito breeding sites and all the larvae. There's a lot that can be done, even when you have these quite low certainty forecasts of what that might mean for disease development, but nonetheless a strong indicator that that it is worth doing some kind of action in advance. I really want to hand over to anyone else on this call, any of the other speakers or anyone else in the audience who also has thoughts on this or advice. Thanks.
Yeah, thanks so much, Tilly. I wonder, Atik, maybe not to put you on the spot, but if you do have any thoughts around El Nino, or I guess climate change more in general, please do feel free, and others as well, please raise your hand.
Hello.
Hi, yep, we can hear you.
Yeah, okay. So as I said earlier, that there was a seasonal pattern in Bangladesh before 2019, but in recent years, this is not working really. I think that's a big impact of El Nino, something like that. I was just looking at the NASA website. So what's going on right now? So maybe our assumption is next year it will be really, really bad for the dengue, particularly in Bangladesh I'm talking about. And yeah, that's it.
Thank you. Thanks very much. Are there others on the call who would like to add anything? No? Perfect. Okay. Well, thank you, Tilly. I think that was a very comprehensive answer. So thank you so much for that. Neeraj, yeah, go ahead.
Yeah, just wanted to, not related to the comment there, but just wanted to share some of the experiences we had regarding the recent dengue response in Nepal. We also tried to anticipate dengue, and we were in discussions with several organizations here in Nepal that work in the sector. But yeah, it was quite difficult to see through this, because it's so difficult to anticipate, first of all, and if we rely so much on data and information, then it becomes even more difficult, because so we were working with FOREWARN Philippines to see if the systems that they have developed will be can work in the context of Nepal as well. And we tried that, although there were some restrictions in terms of the data that we collected at the national level. And later on, we also realized that the historical trends that have been made so far are heavily reliant on the availability of the testing kits in these areas, right? So if we focus so much on the availability of testing kits, then it's quite difficult to see the historical trends, and it's also difficult to see where exactly dengue is sort of an endemic. And yeah, it was always like whether or not this particular city or particular area will likely face a dengue outbreak. In Kathmandu last year there was a massive dengue outbreak, but this year there was another city that went through this outbreak, and it's quite difficult to anticipate these particular regions. And I'm just sharing this with all the presenters as well. I was wondering, in the light of unavailability of data and information for us to anticipate, so what sort of methods would you use, or what sort of proxy indicators could we use to anticipate dengue? And I guess the seasonality, just waiting for a particular season, might not help us get there, because if it would seem more like a preparedness activity rather than anticipation if you don't rely so much on data and information. So I was just wondering, if you don't have this level of technical information that is necessary to anticipate dengue, how would you then anticipate dengue? Yeah, just asking this question to all the participants here as well. We just wanted to get the feedback on that. Thanks.
Thanks so much, Niraj. Yeah, great question. Without the information needed, what proxies can we use to anticipate dengue? I don't know if anybody on the call, Atik, I can see you've put your camera on. Please, over to you.
Yeah, so Ashraf might be the best person to share that, but let me show something. Can you see my screen or?
Not yet.
Okay. Let me try again.
There we go. Yeah.
Now?
Yes, that's clear.
Okay. So we have collected data since 1970, and we cross-match with rainfall and dengue patients.
It's coming now.
Sorry?
Not yet.
Can you hear me?
Yes, it's all clear. Yeah, go ahead.
Okay. So we have tried to identify if there is any pattern and seasonality and any climate variables connected with the dengue. So what we have found that when the maximum rainfall, that I said that from the April, the monsoon season is starting in Bangladesh. And after 30 days, around 30 days, the number is trying to increasing. And when the rainfall is going down, so there is a pattern that the number of patients also going down at the same direction. So that there is a pattern with the rainfall, and there is a very unlikely connection with the temperature, but still there is some correlation with the temperature, humidity, and rainfall, but very strong connection with the rainfall. So maybe you can try to get rainfall data, and if you have the historical data, you can cross-check with them, and with that you can predict the number when you can anticipate the dengue with this data. Maybe it can help. Does it make sense to you?
Yes, it does, and I think that's a really good idea, and we've been doing that at the national level as well. It's just we have such a limited funding that we need to prioritize specific areas, right? So
we have around 50 years daily data of the temperature and rainfall. So before that, we need to clean those data and make them usable. So it's quite long work, but still it makes some sense. So you can try that one if it is possible. So thank you.
And
can I stop my?
Yeah, you can. Can you just hold on for a while? I just want to add a few things. Yeah. So what we found during our studies, like you see the seasonal pattern matches with the number of dengue cases in Bangladesh. And something was, we were trying to understand, like if that is very normal thing or something was really peculiar than the other previous years, because the previous years had also the same sort of like the rainfall pattern, but why it didn't happen last year or like the year before 2019. And this is something here, if you look at that, what was the abnormality of the climate change during on this rainfall was, if you look at the January, February, March, we found that something really unusual behavior that is not like very much climatic pattern. The rainfall happened in February. So early monsoon, very early monsoon rainfall might have a very tremendous impact on the dengue cases. So unusual rainfall might be a very interesting factor to look further if you try to find out also the pattern. Yeah, just in complement what Atik mentioned. Over.
Thank you so much, Ashraf.
Great, thank you both so much. I think that was a really useful response, and I can see, Tilly, that you're keen to follow up as well. I don't know if you have anything that you want to say now. I am conscious that we're almost at time, but go ahead, yeah.
Just very quickly, I think it's a great question, and data is often one of the main limitations on being able to do these like really great time series analysis, to be able to do the kind of regression that you would need to do to say that there is a connection between the rainfall and then the dengue incidence, and also to understand what the lag time might be. So is this 2 months, 1 month, 5 months? There's a lot of really great research. So I guess the way, Ren, that we try and do it in the Climate Centre would be first to look at the academic literature and see for that specific mosquito population, the disease of interest, what is there out there that we can find to try and help us understand some of the connections. So, for example, there's great work done in Barbados and other Caribbean countries by Professor Rachel Lowe, which is looking at extreme weather events and dengue outbreaks thereafter. And so a lot of the research there shows these interesting dynamics of if there are high temperatures or a drought followed by heavy rainfall, then you might see 3 to 5 months later this increase in dengue cases. So you can kind of like find all those studies, pull that together, see if the same mosquito species and maybe the same climactic zone is appropriate in your country, and then perhaps go more, instead of to the mathematical modeling aspect, which is data heavy, you could then try and build along the composite indicators where you would still use your surveillance data of you can see the cases increasing, but before that you can have used those amplifying factors. So like Atik and Ashraful were saying, if you can see that probably rainfall does make sense for this mosquito species in that climactic zone, other papers have suggested it. As a proxy, as you're developing this at the beginning, you could use rainfall and temperature and the specific parameters that have been identified by other researchers early on, and start trying to build, see if it works, and then just iterate as you get more data and information. But yeah, I'll definitely email you, and let's chat about it more. Thank you.
Fantastic, thanks so much, Tilly. I think we'll probably have to call it a day there. We are pretty much on the hour almost, but I just want to say a huge thank you to all of our speakers, Dr. Christopher, who kicked us off, obviously Tilly, you've been fantastic answering all those questions as well, Atik too, and Alexis. Thank you all for sharing your research, your experiences, and everything that you've been working on. I think we can all agree that there's a lot to do, but hopefully everyone else is feeling just as inspired to start cracking on with it and to keep these conversations going. Maybe just to say, we do normally finish off with a photo, so I don't know if people are willing to pop their cameras on just to say hello and have a quick screen grab of everybody who's joined the call. It's been great to hear your questions and your inputs as well. So thank you so much for that, for joining us. I know 2 hours is a long time for a meeting, but hopefully you found it as interesting as I have. Okay, great. I can see quite a lot of cameras coming on. Fantastic. If we could just grab a quick screen grab of that. Brilliant. Thank you all so much. And with that, yeah, I wish you a very good rest of your day, however much you might have left. I know for some people it's quite late now. And yeah, thank you all. And we'll be in touch with the slides, the minutes, the recording and everything. We'll make sure we capture all those links that have been shared. Thank you all again. Goodbye.
Bye-bye. Thanks
So much. Bye.
Thank you. Bye-bye.
See you next year.
Merci,
Merci
au revoir, à l'année
beaucoup.
prochaine.
Merci, au revoir.
Au revoir.
Au revoir.